Because of Bony pyramid is the most invisible part of nose pyramid, sometimes walking this Bony pyramid looks like catching crayfish by the hands.
So, ladies and gentlemen, a warm welcome to the Rhinoplasty podcast. It's a great honor in March that we have got the World Rhinoplasty Day medalists as our speakers, as well as the main judge of that. So today I've got the great honor of having a man all the way from Moscow in Russia with us. Two things that really stand out for me. Obviously, the first one is that he was our bronze medalist at the World Rhinoplasty Day, speaking in English, which is not his native tongue. But the other one is that he's a phenomenal organizer of congresses, and he had an incredible congress in St. Petersburg 2 years ago. So it's a great honor for me to be able to welcome this man on the show that is brought to you by Carl Storz. If you wait until the end, you'll get the email address for the person you can email to get a discount on Carl Storz equipment and instruments. We don't even have to tell you how good they are. Everyone knows what Carl Storz's capabilities are. So, Vitaly, it is a great honor for me to have you here tonight, and welcome.
Thank you very much, Cameron. First of all, I would like to appreciate you for having me here and also for your great efforts. I mean, educational webinars that you have organized in spring and summer during the last year, and also for your amazing World Rhinoplasty Day that I took part.
Yeah,
it's really great honor for me to participate there and also to participate today with you.
Yeah, no, what's great. I mean, this podcast goes all around the world, and you know, many people can't necessarily pay for congresses, etc. So it's wonderful to have the opportunity to speak again about everything that we've spoken about, etc. But before we climb into the topic, which I'm excited to learn about, tell us a little bit more about Vitaly. I know you love the outdoors. I mean, your Instagram, you seem to spend more time out of theater than in theater. How did you end up becoming this plastic surgeon that you are?
I mean, it is long way for all plastic surgeons, and I have finished my university, and then I have residency in general surgery, then PhD in general surgery. I have finished PhD, and then I moved to plastic surgery, and I did residency in plastic surgery in St. Petersburg, and started to work in clinic, and I think it is most interesting specialty.
Wow! And what did you do your PhD surgery in? What was your PhD in?
It was about hernias.
Hernias, jeez. And I guess you don't really miss that with all the stuff you're doing now. Yeah,
it is not my real work now, but it was interesting step in my career. Yeah.
And Vitaly, when you're not working, tell me about your outdoor life that you enjoy.
Yeah, you know, I think we are similar. We have families, and we spend a lot of time with our families, and I like outdoor activities and fishing also, and I have outside house on the lake, and we spend time there together.
Oh, that's great. Now, tell me, the St. Petersburg Congress that you arranged, I don't know how you pulled that off, because you literally had every single speaker of influence in the whole world. I don't think there's been some great congresses, like, even the International Meeting of Rhinoplasty Societies, etc. But St. Petersburg just stands out. How much time and effort did it take you to pull that congress off?
Yeah, you know, we have a team who organize these meetings. I only take care about the program, and it takes around 1 year usually to organize such big meeting. We take all our efforts together, and we spent 1 year to prepare whole program and everything.
And do you have any plans for possibly doing it again?
Yes, of course, but now is not easy time. You know, we moved to internet webinars because of COVID, and I don't know exactly when we can repeat it. Actually, we'll see.
Yeah, well, we hope to meet in person soon because I think everybody's tired of all these webinars. We need to see each other and greet each other and work together again.
Yes, of course. Yeah, we are missing it, but it is not depends on us. We'll see how it will be this COVID, and when it will be possible, of course, we will try to organize it again.
That's great. Okay, so Vitaly, I want to ask you to share your screen and climb into the topic that you want to share with us. And I remind you that many people will be watching it on YouTube, but the majority will be on all the various streams that the podcast's going out. So they won't necessarily be able to see what you are going to be able to show us. But as you talk, I'm sure you'll be able to explain to somebody who can't see your presentation.
Okay, it takes maybe 1 minute.
And Vitaly, whilst you're getting that ready, tell me about the World Rhinoplasty Day. I mean, it's great that you took part. You had a fantastic team from Russia, and what a pleasure to be able to be one of the medalists, man.
Yeah, it is great. It is great opportunity to participate this famous rhinoplasty speakers from around the world, and it was really nice and amazing experience. And again, I appreciate you for this fantastic possibility to take part in.
Right.
Yeah, I'm ready to talk about sequential approach.
Please, yeah.
Can you see my screen?
I can see it.
Yeah. Can see?
No, I can see it, but now you just want to maximize it as if you're doing a presentation.
Okay. Yeah.
Okay, there we go. So, Vitaly, thanks. Please share your screen and go ahead. There, I can see your presentation now. Thank you.
Great. Yeah, I am ready to talk. I already talked about that, but I like to repeat it. I would like to talk about one of the most difficult topics for all rhinoplasty surgeons, about treatment of bony pyramid. And I think it is really difficult. Why? Because there are three main issues in bony pyramids. That bony pyramids is the most invisible part of the nose. When we perform rhinoplasty, it's most difficult to make diagnosis because it is most cephalic. And it's very difficult to see all the deformities of bony pyramids. And the second issue is bony pyramid is one of the biggest part of the nose pyramid, and it is foundation of the nose. And bony pyramid is asymmetric in the majority of patients undergoing rhinoplasty, and because of that, I think it is one of the most difficult part of rhinoplasty for all rhinoplasty surgeons. And I like to talk about my own experience working this bony pyramid, and also I would like to present my algorithm working this bony pyramid. Because of bony pyramid is the most invisible part of nose pyramid, sometimes working this bony pyramid looks like catching crayfish by the hands. We cannot see exactly where is deformity. We sometimes should only imagine what is the deformity there. And because of that, I prefer to use full open approach. What means full open approach? It means that I mobilize periosteum from the bony pyramid using elevator from the cephalic part of the bony pyramid till caudal part of the bony pyramid, from anterior-posterior direction, and from one horizontal part of maxilla to another horizontal part of maxilla. It means these directions, this approach helps to visualize all the problems of the bony pyramid. And for example, you can see I can visualize such big holes on the surface, or some convexity or some concavities. It is not the secret that all bony pyramids are very different from each other, and it's also well known that bony pyramid is one of the biggest part of the nose pyramid. It's a foundation of the nose, and it also occupies from 1/3 to 1/2 of whole nose pyramid and gives stable foundation for cartilaginous part of the nose. You can touch your own bones and you can see that it is quite big. It gives stable foundation for middle third and for lower third also. And it is also not the secret that the nose pyramid is destabilized completely. Very difficult to get the stable position of the bones in the end of the surgery. And also very interesting question, how to fix this destabilized bones and the required position after complete osteotomies and save it in this exact position despite their possibility for the bones to shift under the influence of different circumstances like swelling, scarring, etc. I think it is one of the main issues that we should think about because predictability of the rhinoplasty, it is key. And minimization, I think, minimization of complete bone destabilization preserve us from the undesired shift for the middle and lower third of the nose also. And these decrease the number of undesired asymmetries that can be one of the main reasons for their revision surgeries. And I think we should appreciate stability of the bony pyramid, this preservation of the stability, if it is possible, of course. Also, bony pyramid is asymmetric, as I mentioned before, and you can see in this picture that we have opened together. This Peter Paul has in his amazing lab. We have opened 3 random bony pyramid, and you can see that right and left side on each bony pyramid is different, and it is usual thing for most of rhinoplasty patient. Right and left side are different, and how we can treat different problems, these symmetric osteotomies, for example, or asymmetric osteotomies. Sometimes I don't know. For example, in this particular case, you can see that one side of bony pyramid is convex, another side of bony pyramid is concave, and what type of osteotomies should we perform here, for example, to get symmetry? I personally don't know how to get real symmetry with these osteotomies only, and how to get predictability during this process. Because of that, I think that necessary and desirable component of nose job is rhinosculpture. What means rhinosculpture? It means we should remove the asymmetries using some type of rasps. But rasps is not easy to work in horizontal part of maxillary areas, in base of bony pyramid, for example, or also very difficult to work with traditional rasps in the upper part of bony pyramid. Because of that, I think much easy to work with Piezo equipment, and Piezo equipment, Piezo rasps helps to work in different areas of bony pyramid, and we can easily remove the thickness of the bone, and we can easily improve the symmetry between right and left side in many cases, especially in cases this not so big hump. It can be only rhinosculpture. For example, in some asymmetries, like in this cadaver bony pyramid, where I did only rhinosculpture, it is not necessary to perform any type of osteotomies. I can perform only rhinosculpture. I can get much more straight and much more narrow bony pyramid to get successful result, and very predictable, because if I don't break the bones, I don't get any destabilization and unpredictable movement of the middle third and lower third also. And you can see that in this particular case, I did only rhinosculpture, and it is real improvement in close-up view of the upper third, because of absent of destabilization and possibility to symmetrize, make more symmetrical right and left side. simply removing the thickness of the bone. Because of possibility to visualize all the problems, because of possibility to perform rhinosculpture, I little bit changed my algorithm during last 5 years, and I almost always use full open approach to see, to look at the nose pyramid, to visualize all problems, and then I start almost all rhinoplasty is rhinosculpture. I try to make symmetrical right and left side, and then if it is necessary, I can perform any type of osteotomies. But in this particular talk, I prefer to talk not about dorsum preservation, because there are some guys like Miloš and Aaron and Dean now and Miguel, and Sam most already talk about that, already talk about dorsum preservation, and they're very experienced in this area. Also, there are very good experienced surgeons from Turkey now, Göksel, Barish, who already presented their talks about dorsum preservation. I mostly now will tell about dorsum reconstruction, because in northern part of Russia, where I mean in St. Petersburg, we have a lot of patients without big humps. We have a lot of patients with small irregularities in the dorsum or wide dorsum, but some of them are quite low dorsum, and they don't need to remove the humps. Many of them need just to improve their dorsal aesthetic lines. In such cases, I prefer to perform dorsum reconstruction or dorsum augmentation, these incomplete osteotomies. But of course, I also like to perform dorsum preservation for appropriate cases. But in this particular talk, I will tell mostly about reconstruction of the dorsum.
No, that's great, Vitaly. Thanks. Because to me, I think we can lose it sometimes by being too focused on the whole dorsal preservation. And it's so interesting that the patients that you're seeing don't necessarily need that, but it's the rhinosculpture. So it's interesting you say how your approach has changed. How many years have you been using Piezo for now?
I have been started to work with Piezo on 2016. Now I use Piezo for 6 years. For 5 years.
Oh, that's great.
And
okay.
I'm really happy with this equipment, and I cannot imagine myself now these osteotomes only, because I think it is another level of understanding and another level of results, because you can really get almost symmetric bones in the end of the procedure using Piezo. That's a big difference from my previous experience working only these traditional instruments. Then was really impossible sometimes to get symmetry between right and left side, for example.
Well, that's fantastic. Do you carry on?
Yes, and my working steps, working this Bony pyramid are a full open approach, as I mentioned before, rhinosculpture. Rhinosculpture I perform for all patients, almost all. Of course, there are some cases this ideal Bony pyramid, but in my practice, maybe it's 1 or 2% only. Also, I perform a lot of secondary procedures, and for almost all secondaries, rhinosculpture is necessary, because most of them already had osteotomies, and some of them had multiple osteotomies before, and they have different irregularities on Bony pyramid, and rhinosculpture helps to perform much less secondary or tertiary osteotomies. In many secondary cases, you just need to remove only some irregularities on the bony surface again. But of course, if there is hump, I can remove hump. If this case appropriate for dorsum preservation, I now prefer also to perform dorsum preservation. But if it is necessary to perform dorsum reconstruction, as I mentioned before, in low dorsum, in wide dorsum, in low radix, I prefer to perform, or in crooked nose, I prefer to perform dorsum reconstruction. And in these particular cases, I started this incomplete partial osteotomies. What means partial osteotomies? I will explain later. And if it is impossible to get ideal result, or not ideal, but desired result, in the end, this procedure, I can complete the osteotomy lines and can perform complete osteotomies. But in my algorithm, complete osteotomies is the last step. And full open approach, I already presented. Again, I mobilize periosteum from the bony pyramid, from the caudal part of the from the keystone area till cephalic part of the radix, and then from one horizontal part of maxilla to another horizontal part of maxilla. It's quite wide mobilization of the periosteum, and it's really very helpful to get possibility visualize all problems on the bony pyramid, and then I can treat these problems. For example, if one side has convex deformity, another side have concave deformity, I can remove convex and can remove area around concave deformity to get more straight surface on one side and more straight surface on another side. And then if it is necessary, I can smooth this surface with more precise rasps, like diamond rasps. And also very important to check the thickness of the bone using CT scans. I always ask patient to bring CT scans. It gives very good possibility to prepare patient and yourself to this procedure, because CT scans, especially cone beam CT scans, helps to predict the thickness of the bone, and I can prepare myself and patient how much millimeters I need to remove on each side to get more straight and more symmetric surface on the bony pyramid. And then if it is necessary, I remove the bony cap. Of course, it is not necessary in all cases, but if it is necessary, after removing the bony cap, I can visualize the middle third. I can visualize two shoulders of the roof and can treat them removing the shoulders and using asymmetric or symmetric spreaders, for example. There are some cases and I have used only rhinosculpture. For example, in these particular cases, she has very interesting bony pyramid. You can see that the base of the bony pyramid is convex and the middle part of the bony pyramid is concave. And in this particular case, if you, for example, perform traditional osteotomy, you cannot treat the base of the bony the pyramid, because traditional osteotomy usually performing in maybe little bit lower than nasophacial groove, but you cannot treat this convex deformity in the deep base of bony pyramid. But if you moved inward this bony pyramid, this osteotomy, you can very easily create the collapse of this nose pyramid. And I think it is easy just to remove the convex in the base, in the deep base of bony pyramid, and you don't need to perform any osteotomies. You don't need to move inward this collapsed area, concave area. And I did this algorithm, I remove the base of bony pyramid, because the base of bony pyramid usually is quite thick, between 4 and 5 millimeters thickness can be in this area, and I easily can remove 2 or 3 millimeters on each side. And in your particular case, you can see how improved the frontal view because of rhinosculpture only. I didn't do any osteotomies, and also I used asymmetric spreaders for her middle third, and didn't do any destabilization, and it is very predictable. I mean, for example, before when I performed a lot of complete osteotomies, sometimes I slept very nervous, because never know how it will be after cast removal. You never know, because it can be swelling or something can happen. And I also felt sometimes some type of cold sweat during the procedure, because it is not usual, but sometimes you can move inward a little bit more, and was very difficult to fix the problem. I mean, complete osteotomy. When you don't perform any osteotomies, you sleep very well. You sleep very patient. I mean,
so Vitaly, I've got a question there for you. You're mentioning that it's up to 5 millimeters thick, and that you're going to do a cone beam CT scan beforehand. So a concern for me would be that the bone becomes too thin. But you can, with your piezo, look very carefully to make sure that you don't thin the bone out too much, eh?
Yes, of course, you can control the thickness of the bone that you removed, and also you can control the red flux. What means red flux? When the bone changes the color, it is very visible. It means you are close to thinning the bone. Yeah, and when the bone changes the color from white to red, you should stop. It's very easy to control.
Fantastic.
And in this particular case, you can see again, I didn't perform any osteotomy. I did only rhinosculpture in the base of bony pyramid, and it is very good and very predictable result. I think because of that, because of absence of osteotomies. This case is 2.5 years, close to 3 years now, and she had quite wide nose pyramid. Again, it is typical patient from Russia. It's like mix between Asian and Caucasian noses. It is not big hump. There is no hump. It is wide base, wide middle part of bony pyramid, and bulbous nose tip. And I did rhinosculpture only, and put narrow DCF graft on the top of the bony pyramid and on the top of the middle third. I didn't open the middle third, and you can see real improvement, and you can see that her dorsal aesthetic lines much narrow now. Again, I didn't perform any osteotomies. I did rhinosculpture only in her case. Also in our area, I mean in northern part of the Russia, there are a lot of patients with extremely thin skin, and extremely thin skin means for me that all small defects can be visible 1 or 2 or 3 years after surgery. And for example, this exact patient has extremely thin skin, and you can see all shadows on the surface of her nose, and her middle third was crooked, and her middle third was very asymmetric because of asymmetric upper laterals. You can see that her left upper lateral longer and wider, and because of that she had a very interesting type of hump. She had some type of lateral hump. And I don't know how to treat this type of lateral hump, for example, this dorsum preservation, and it is difficult to treat, and you need only to reconstruct middle third, and you should use spreaders in her particular case. But what is the necessity to perform again osteotomies in her particular case? I didn't perform any osteotomies. I treat her bony pyramid with rhinosculpture and treated her middle third with spreaders, have removed the asymmetry and excess of upper laterals, and again you can see how smooth and symmetric nose pyramid and the dorsum 2 years after surgery. By the way, we have published our experience in rhinosculpture, these piezoelectric instruments for dorsal preservation. I think it is also dorsal preservation, but it is separate part. It is bony preservation. Together, this Olivier Gerbeau is this amazing Bible of preservation rhinoplasty, 3rd edition, published by Roland Daniel, Peter Palha, Yves Saban, and Boris Chikir. It's honor for me to be this.
We're going to be interviewing all of those guys later on in the year, so I'm looking forward to that.
All of them are great surgeons and great guys. Yeah. Of course, sometimes we need to perform osteotomies. It is impossible to treat all bony pyramids with rhinosculpture only, because some bony pyramids can have very thin bones. It is visible on CT scans. Some bony pyramids needs to move inward the base. Some bony pyramids you need to move inward one side, outward another side. I mean crooked bony pyramids, or another type with big humps or something like that. But again, in case of dorsum preservation, I use another way. But in a case when I plan to perform dorsum reconstruction, I use this algorithm. I start usually this type of incomplete osteotomies. What means incomplete? It means that I perform lower lateral, for example, osteotomy, and incomplete transverse osteotomy. I try to leave bony bridges, like in this particular picture you can see I didn't complete the osteotomy lines, and in small humps, in patient is absent of hump, in patient on patient is this little bit wider bony pyramid. This step can really improve the base of the bony pyramid, because when you perform lower lateral in transverse osteotomy incomplete, you can easily move in 1 or 2 millimeter this bony side wall without complete destabilization. It's interesting, but it works very well. For example, in 3D animation, it looks like, again, complete lower lateral osteotomy and incomplete transverse osteotomy line and nothing more. But before, of course, I perform rhinosculpture. And you can see on video how it works. And right after this procedure, you can see that the bony side wall of bony pyramid, right side wall, moved on inward for 1 millimeter. In many cases, in many patients, it can be enough. For example, in this patient, this plateau on the top of the dorsum, before 2 years after surgery, you can see she looked very nice and symmetric, without, again, total destabilization of the bones, only this rhinosculpture and incomplete or partial
Vitaly,
osteotomies.
I have a question for you. If you can see you're probably going to have to do an incomplete osteotomy, do you not first do the incomplete osteotomy and then do the rhinosculpture, or do you rather first do the rhinosculpture and see if you've been able to address the problem, and only then will you go a step further and do an incomplete osteotomy?
No, I think that rhinosculpture should be first, because rhinosculpture helps to really symmetrize the bones. Yeah, it is first step. Then I can get smooth surface. Smooth surface will be visible like smooth bony pyramid after procedure in 1 month or 2 months or 2 years. You always will see the smooth surface, and because of that I prefer to remove the asymmetries, this rhinosculpture, and then if it is necessary I go this asymmetric, or not asymmetric, incomplete osteotomies.
Okay, great. No, thanks for that.
And there are some results like that. I like to check all patients this helicopter view. I think it is one of the main view for examination of the bony and cartilaginous dorsum, because without helicopter view you cannot see exact problem, you cannot see your exact result. And one more case, again, this incomplete osteotomy, this complete lower lateral and incomplete transverse, this big bony breach on the top of bony pyramid. And I didn't do again, I didn't join the lines of osteotomy. It was not necessary. I did rhinosculpture and incomplete osteotomies and slept very well.
Yeah, that's great. For those of you who can't see, they are astoundingly good results.
Yeah, but because of predictability, again, I think that we cannot control swelling, for example. Nobody can control swelling. But if you didn't break the whole construction, if you didn't break the foundation, it's very easy to predict. It's like absolutely predictable. But if you break it, broken bones can move outward, can move inward in some places. You never know when will be the final position of them. Of course, when you perform dorsal preservation, for example, it's a little bit easy to control because you didn't separate one lateral wall from another lateral wall. It is like pyramid, yeah? It's only movement of pyramid, but it is not movement of each wall from each other. But when you perform traditional complete osteotomies, it always can be in different positions, I mean. And not all of course, but my main problems in my previous practice before 2016 was these osteotomies. And my main headaches, because I couldn't control the bony pyramid, I think was these osteotomies. Again, incomplete or partial osteotomy, sometime I can add medial oblique osteotomy, but I always try to leave bridge between medial oblique osteotomy and incomplete transverse osteotomy. You can see this bony bridge is much smaller. It's like between 3 and 5 millimeters or 3 and 4 millimeters, but it also keeps quite stable position for the whole bony pyramid, because it is not destabilized bones. It is fixed bone, one lateral wall and another lateral wall. It is not the green stick. It is real bony breach that helps to avoid movement of the bone in one side or in another side during the rehabilitation process, during the swelling process. And this little bit much more movement, but again it is easy to control the final position. In such cases like this, for example, in this cadaver bony pyramid, you can see that you can easily move the bone inward, leaving this bony breach. And if I need to move a little bit more, I can drill the hole, or I can use different thickness of the spreaders. For example, I can put one spreader thinner, one spreader thicker, and suture them together. And it gives possibility to keep stable position of the bones and at the same time move one bony side inward little bit and move another bony side outward little bit. But it is not for crooked nose, for really crooked nose, but it is for small asymmetries. Like in this particular case, you can see that one side, one bony side is little bit convex in the upper part and concave in the middle third, in the base of middle third, and I moved little bit this side outward and moved little bit left side inward using asymmetric spreaders, this type of incomplete osteotomies. And you can see that 1.5 years after surgery, it looks very symmetric. It looks almost symmetric position of the right and left bony walls. And again, helicopter view for
But it's so precise. I love it that you're so in control and precise, because yeah, this piezo really gives you that ability to do that.
Yes, I think it's because of piezo. It is first reason, but that's the second reason that I didn't destabilize completely the bones, because as I mentioned before, I don't know how to control bones if they was broken, totally broken. I don't know. For me, it is main guess, still main guess, how to control final position of the bones if you break them, and how to control them during the rehabilitation period, during the swelling process, because swelling can easily move them in different directions. It is two reasons that helps to get more precise results. Again, you can see that in your particular case was asymmetric bony pyramid, asymmetric middle third, and again I did rhinosculpture and incomplete osteotomies, and you can see 1.5 years she got really straight dorsum, this symmetric, much more symmetric right and left lateral bony walls. But of course, in some asymmetrical cases, in some crooked noses, impossible to get symmetry, these symmetric osteotomies, because if one side extremely concave, another side extremely convex, you need sometimes to move one side and inward, for example, and move another side outward more than 1-2 millimeters. For these particular cases, I prefer to use this type of asymmetric osteotomies. This is 2 paramedian osteotomies, and I usually remove piece of the bone on their convex side. And concave side, I perform paramedial only one osteotomy and transverse osteotomy. These dotted lines are not osteotomy, it is scoring on the bones. This is long bridge on the base of the bony pyramid on the one side, and this is again a long bridge on another side. And this type of osteotomy helps to move one side inward and another side outward. And in such cases, I can put spreader only one side, like in this cadaver bony pyramid, for example. I have removed piece of bone using 2 paramedial osteotomies on her left side, moved outward her right side, and put one thick spreader, sometimes from the rib, to get more symmetric middle part of bony pyramid. But in such cases, like real asymmetric cases, crooked noses. It works not in all, of course, not at all, but in many of them it works very well. And this is tertiary patient. She had 3 rhinoplasty before, and you can see how crooked her and unparalleled her dorsal aesthetic lines. And after this procedure, I performed rhinosculpture and this asymmetric type of osteotomies, partial osteotomies. I didn't mobilize her bony pyramid completely. I moved her left bone outward, right wall or bony wall inward, use thick spreader on her left side, and you can see real symmetry. You can see that she looks much better and her dorsal aesthetic lines are parallel to each other. And some another views, and of course I did reconstruction of the tip, and I did reconstruction of the alar. And I would like to tell about our paper, what we did together, this Peter Palhazy, Olivier Gerbeau, and Roland Daniel, about this approach, sequential approach to managing bony vault. This article was published in 2019 in Aesthetic Surgery Journal. And now we prepare article about bony pyramids, about classification and different types of bony pyramids. I think it will be interesting. Hopefully we'll publish it soon. And this is my experience. It's interesting that during my working period, this Piezo, from 2016 till 2020, I have performed rhinosculpture only in 30% of all my patients. It means every third my patients, I didn't do any osteotomies. In 40%, I have performed lower lateral and incomplete transverse osteotomy. It means 70% I have performed rhinosculpture plus incomplete osteotomies. And in 17% more, I add medial oblique osteotomy. And again, I didn't complete. But only in 4% of all my dorsal reconstruction cases, I did complete osteotomies. It was not necessary to join osteotomy lines in 96%.
Sure, that's very interesting.
It is my experience. But my group of patients are a little bit different, for example, from Turkish patient, or from Mediterranean patients, or from Caucasus patient. I mean, because we are living in between Caucasus and Asia, and we have a lot of different type of patient. I mean, this wide dorsum, or this low dorsum, this maybe normal dorsum. You know, I think you have seen Russian girls. Yeah.
Yeah, a lot of pretty Russian girls once they've gone through your hands.
Yeah, but most of them would like to get as much as possible straight noses, and
yes,
most of them like to get really symmetric noses. And I think it is a way to get symmetry, but it is a little bit maybe longer to change your mind, because when I studied, I studied to perform complete osteotomies. But now I maybe exclude dorsal preservation, foundation dorsal preservation cases. I perform complete osteotomies only in extremely crooked noses, maybe. I don't need to perform such a lot of destabilization of the bony pyramid, because it is unpredictable in my hands.
Yeah, I think Vitaly, I mean, Olivia has done such groundbreaking work with Piezo. I think it's going to become much more mainstream. I think it seems that the cost is the one thing that stops a lot of surgeons from being able to use it. But I know of many guys who don't use it just as a once-off. They will continue reusing the different heads to try and make it more affordable for the patients.
I think you're absolutely right. Olivier did a lot of efforts to involve Piezo in usual rhinoplasty life, and I have visited him in 2016, and because of him I started to use Piezo in all my rhinoplasty surgeries. But I know that every year more and more rhinoplasty surgeons start to use Piezo in their usual practice. For example, Dean Tuumi in this year last year also started to use Piezo. Rick Davis started to use Piezo. Before he used only electropower instruments. And I mean, most of all genius rhinoplasty surgeons around the world started to use Piezo nowadays, and I think it will be usual procedure, rhinosculpture or using Piezo equipment for most of all rhinoplasty in some years.
So give us your conclusions here, Vitaly.
Mm-hmm. I think the advantages of this approach are exact diagnostic. Because of full visualization of the problem, we can see everything and we can control and we can treat all the problems. For example, asymmetries or convexities or concavities or some irregularity on the bony surface. Also, it is possibility to make bony pyramid more symmetrical, and in case of need, it is possible to perform incomplete osteotomies. We don't need to perform in all cases. We don't need to perform complete osteotomies. We don't need to destabilize the foundation of the nose pyramid, and I think it is less trauma and it is maximal control of the most difficult part of the rhinoplasty.
Sure. Well, I've been able to use the Piezo down in Cape Town. We've only got one machine in South Africa that's doing the rounds. There are a few guys who've bought them, and we're going to be buying ours for Port Elizabeth in the next couple of weeks. So I'm quite excited to be able to use it full time when I'm operating here in Port Elizabeth and not just if I'm in Cape Town.
Yeah, you will enjoy this Piezo. Yeah, it's absolutely.
So Vitaly, what I'd like to conclude with is, so Piezo has been a big change for you over the last 5 years. For the young guys who are listening to the show, where do you think rhinoplasty is going to go in the future? What would you want to say to somebody if they knew in wanting to become a really good rhinoplasty surgeon? What are for you the really key fundamental things somebody has to get under the belt before they go out there and, like Rod Roerick says, everyone's world famous on their own website? How do people really get good at doing rhinoplasty?
I think the key is analysis. I think the key is analysis, because when I think about my previous years, I always try to improve my results. How I can improve? I should spend more time performing analysis of the nose, performing analysis of your own results. And now when I analyze my results from previous years till 2015 till 2014, I don't like almost all my results actually, because from 2014 maybe I started to perform much more analysis when I performed rhinoplasty, before rhinoplasty, and I started to make picture of all my procedures. I started to make maybe 100 pictures during the rhinoplasty. It gives possibility to analyze what I did during the procedure and when I did mistake during the procedure, and I really improved because of that. and also measurements.
Well,
Analysis and measurements. It is two keys for your own analysis and your own measurements.
Yeah.
And so spend more times this your database, this your result, this your photos from surgery room, this your videos, and also I think the third key is relations. These professionals, these masters, because masters can learn or can give you much more experience, much more knowledge, because they already got it during their life. And I appreciate my teachers, I appreciate great surgeons, masters, whom I learned a lot.
Yeah. Yeah, no, those are wise words, Vitaly. And analyze, measure, and learn from the top guys. It reminds me when Miguel told me a few years ago in Portugal, he said to me, Cameron, if you do not take photographs intra-operative, you didn't do the operation. And I was like, wow. Yes. And I do that now. I've got somebody who just takes photographs the whole time. And then when you speaking about, it's only been like maybe 7 years ago that you're starting to feel more satisfied with your results. I remember Faisal Payden saying to me, Cameron, you've got to, after your first 100 rhinoplasties, then you go to another city and you open up your practice. And I'm also reminded by when I visited Spencer Cochran in Dallas, he's got like a picture book of befores and afters for the patient to look at. And I was saying to Spencer how impressed I am with the results. And he said, no. And he paged through. There must have been maybe 250 photographs in there. And he pointed to one only and he said, that's been my perfect nose. Everything else, there's a little bit of something that wasn't excellent, perfect. And I think that absolute strive for excellence is what puts you guys ahead of the rest of us. Yeah, man, Vitaly, that was great. I'm looking forward to going to, I'm back in the OR tomorrow actually with a deviated nose, and I want to see how I can use these principles that you've shared with us to put it into practice. So I hope that all the listeners around the world have enjoyed this as well. So now that you've made it all the way to now, I can give you the email address for the Carl Storz representative. And if you email this man and you say to him that you were on the Rhinoplasty podcast, you're going to be able to get a discount on some rhinoplasty instruments from Carl Storz. And the email address is, so it's, you've got to get your Zulu right to get this. It's smazibuko@carlstorz.co.za. I'll spell that for you. It's s.mazibuko at Carl Storz, that's KARLSTORZ.co.za. So s.mazibuko@carlstorz.co.za. So Vitaly, that brings me to the end of tonight's show. Thank you very much for taking time off to share with us an hour of your pearls of wisdom. And we really it's such an honor to have you on the show. And I think this hopefully will be teaching rhinoplasty surgeons around the globe how to get better at what they're doing.
Thank you very much, Cameron. It was really honor and pleasure for me to be with you, and I hope that it will be helpful for maybe some surgeons who would like to improve their practice and their results.